السلام عليكم ورحمة الله وبركاته. مساء الخير جميعا. أهلا وسهلا بكم في هذه المحاضرة ضمن مبادرة تجمع طلبة الطب حول المملكة. معكم سعود الودعاني، سفير كلية الطب جامعة جازان. نرحب بجميع الحضور من طلاب وطالبات الطب من مختلف جامعات المملكة. حياكم الله، ونتمنى لكم محاضرة علمية ممتعة ومفيدة بإذن الله. شرفنا اليوم استضافة الدكتور باسم حسن الشريف. حياك الله دكتور، استشاري الجراحة العامة وجراحة المناظير وجراحة الإصابات والحوادث، حاصل على البورد الكندي والأمريكي في تخصص الجراحة، ورئيس شؤون المستشفيات في جامعة أم القرى، ومدير برنامج الجراحة المشتركة الثاني. نرحب فيك دكتور باسم ونتشرف بتواجدك معنا اليوم. تفضل دكتور.
حياك الله سعود. الصوت واضح؟
اي دكتور صوتك واضح، بس ارفع صوتك شوي.
ايش هو؟ واضح الصوت السلايدات؟
اي نعم واضح دكتور.
طيب. بسم الله الرحمن الرحيم، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. اللهم أرنا الحق حقا وارزقنا اتباعه، وأرنا الباطل باطلا وارزقنا اجتنابه. حتى نتشرف بوجودي معكم اليوم، وإن شاء الله إنه الجميع يعني استمتع بالمحاضرة ويستفيد حاجات تبقى له في مسيرته العلمية والمهنية يا رب. طبعا لما طلب مني أن أقدم حاجة عن التروما I looked for around and I found this program. I think the most suitable as most of our attendees are medical students. So this is a program directed for medical student. It's like a mini ATLS course. Mostly it is direct to medical student, nursing student, other health care involved in trauma patient, and it is well-structured program, part of the American College of Surgeon trauma-related programs like ATLS or pre-hospital trauma care and evaluation. So these are their slide. It's a credit of the American College of Surgeon, and I'm the course director and instructor in the course. I use them to present. So just for disclosure, it is a slide shared by the American College of Surgeon. What I'm presenting today is their second edition, and I think the third edition was released a few months or years ago, but it's almost the same. I'm sure all of us are dealing with trauma as students or healthcare professionals. I'm sure you, as a medical student, wherever you go in any hospital, you will deal or see or help in managing a trauma patient. Dealing with trauma, I think, has its own circumstances. It has its own stresses. You are dealing with a healthy patient who was just a few minutes ago walking around normally with no prior disease, and all of a sudden he sustained this trauma. And it is your role and your job to make sure that minimum injury he receives. I definitely don't want to aggravate his injury, and you want to get him safe back to his pre-trauma status. Dealing with trauma is always stressful. In residency programs, trauma per se, it is stresses the resident or the specialist or even the consultant, because it is associated always with fast, quick, sharp decision. You either take this patient to OR or you either, for example, intubate this patient, or you have to put this patient chest tube, you have to do DBL. So all these decision comes within minutes of assessment. You don't have sometimes the privilege of investigating the patient, or doing CT scan, or waiting for laboratory work to come out. So always trauma is has its own circumstances and its own merits when it happens. So in trauma care, you always want in trauma care, you always want to get rapid, accurate physiological assessment of trauma patient, and always focus on the word rapid. So you want to be quick. You don't have the privilege of an hour or maybe 30 minutes. No, you have to evaluate this patient within 5 minutes. You have to make a decision within 5 minutes. We always resuscitate, stabilize, and monitor patients by priorities, and it's always been ABCD. Although recently there is some minor changes, maybe I'll talk about it in a minute. During assessment, you have to think what is your next step. So you are doing something now, and your mind already moved to the next step, which is you want to get this patient into their definitive care quickly. And trauma care is the ideal example and the best module for teamwork. So when I'm as a trauma leader, evaluating a patient, I'm always with a team. Somebody is taking care of the IV line, somebody is taking care of the airway, somebody is taking care of covering the patient, and another person doing, for example, fixation of a fracture. So it's always team. It's not based on one person show. So we during the lecture we'll talk about the patient history. We will go through importance of the injury mechanism of anticipating the injuries, and we'll talk a little bit about team work. As you know, in Saudi Arabia, RTAs, or road traffic accident, or motor vehicle collisions, maybe is the number one cause of death, morbidity, and mortality in Saudi Arabia. Fortunately, we don't have a lot of penetrating injuries. We don't have a lot of explosion, but road traffic accident, whether car accident or pedestrian accident, has a major cause of people death, as well as their disability, and being handicapped for a long time. So usually, if you want to prevent a problem, you have to analyze it. Why this happened? You have to get teamwork working around you, and evaluating these problems, doing studies, doing a statistic, and you communicate with higher authorities. And now in MOH, Ministry of Health, there is a huge project of trauma prevention by public awareness programs, by putting a lot of penalties of people breaking the traffic roads, and it's proven, it is seen that this is reduced the trauma. And as you guys know, in 2023, sorry, 2034, we are hosting the World Cup, and this will be a huge project, like nationwide in terms of trauma, because as you know, when people gather, there will be a trauma, whether car traumas, gathering traumas, like a lot of kind of trauma. It's like a high season, but on a little bit way bigger and wider across the kingdom. In trauma, there is three stages where patient might die immediately. Stage number one, or the first phase, immediately after trauma, and you can see here when people sustained major trauma and on the scene, patient will die. They will not even walk out of the car. As soon as the accident happens, somebody, for example, roll over and he was driving like 180 kilometer per hour. They were ejected from the car and they just landed and sustained head trauma. He will not make it to the hospital. So this trauma patients dies in three phases in during trauma. Phase number one, when they sustain major trauma, which is incompatible with life, like they die on the scene. For example, somebody who sustained head injury or decapitative neck injury, he was decapitated. Somebody who sustained major free aortic rupture of the aorta, they just die on the scene. This is where you don't have a lot to do. As soon as the trauma happen, patient will die, and nothing you can do. And third stage or third phase in trauma death, where patient might die late into trauma, like weeks or days, where they die from complication of the surgery or the trauma itself, or stay in the ICU. For example, somebody came in and we did a trauma laparotomy and we did bar section, and after weeks he developed wound infection and sepsis and died. Or somebody who had head injury and with being in the hospital for a long time, he developed hospital acquired pneumonia and they die. So this is a late cause of death, and this is again, it's not where we try to make an impact. Here, the early death, where all the ATLS courses, the team course I'm presenting, other training courses, we try to improve the outcome of the patient. So in the first 2 hours of patient arrival to the hospital, or the first 2 hours in patient trauma. This is where it is proven if the patient went into a center where he was treated by well-trained personnel, the outcome will be totally different if he went to another hospital or another center where there was no well-trained people taking care of him. So this is where we try to train you guys as medical student or resident to take care of patients. Right. Team principles. There's few principles I want everybody to remember, to practice, to do throughout their life, from day one of treating patients into the day they retire. Always treat the greatest threat to life first. So we don't get distracted by the obvious. We go by principles of ABCD and treat accordingly. For example, somebody came in with a major wound into their side and ugly a wound which is oozing, not actively bleeding, but it's oozing, but it is very ugly and it is destructive. So you don't go and treat this fracture or this injury because you might miss a tension pneumothorax, which is more important, but unfortunately we don't see, right? Because it's inside the chest, so you don't see it. So this is where you go by treat the greatest threat to life first. The second principle, you don't need to get a definitive diagnosis. You don't need to know, for example, type of head injury. Somebody came in with a GCS of 8, need to be intubated. He doesn't, or she, you don't need to know that he has epidural, subdural, or intrabronchial hemorrhage, right? You need to know that this patient has a head injury. So this is where you don't need to get a definitive diagnosis. We go by physiological approach. Physiological approach, this means you go by vital signs, you go by urine output, you go by response of your resuscitation of the patient and how he responding to your resuscitation in terms of physiology. Second principle is time. Time is always essence. Time, like anything else in our life, it's very important to consider time. It's very important to deal with the patient within minutes or hours. We talk about ABCD evaluation. We talked about intubation. We talk about scans, we talk about intervention, fixation of bone tissue. All of these is not ours. It's not even our. We always try to do everything within 60 minutes of patient arrival. So time is essence. Time is very important. So always don't get involved in something and the time elapses and all of a sudden you find that you are resuscitating a patient for 6 hours without a definitive plan. So this is completely wrong in trauma management. Other principle is do no further harm. This means if you don't know anything, you don't do it first time in the patient because this is will harm your patient, and this is where trauma patient dealt with by multidisciplinary team, dealt with by people who are expert. And always it's a team work. It's not a single person work. Work is not a single person job. So always there's a team leader. There is anesthesia looking after the airway. There is surgeon looking after the chest and abdomen. And there is an orthopedic person looking after the fractures. Okay. Any questions so far, Saud?
اي دكتور، صراحة في طالبة تسأل تقول أنا طالبة في السنة الخامسة ومهتمة بتخصص تروما سيرجري وحابة أبدأ أتدرب في هذا المجال، بحكم إني في جدة فين ممكن ألقى فرص تدريب مناسبة؟ وإيش الخطوات أو الأشياء اللي المفروض أبدأ فيها من الآن إذا كنت مهتمة بهذا التخصص؟
معلش سعود، السؤال الأول إيش هو؟ فين ألقى؟
فين ممكن ألقى فرص تدريب مناسبة؟
أوكي، في المستشفيات اللي فيها تروما، يمكن في جدة كل المستشفيات الحكومية، سواء الملك عبد العزيز اللي هو المحجر، الملك فهد، مستشفى الملك عبد الله، ومستشفى شرق جدة، كلها فيها تروما وممكن إنها تشتغل أيضا في الطوارئ أو في قسم الجراحة. طبعا عشان أنت تكون تروما في تو باث، الجراحة اللي زي ما أنا سويت جراحة وبعدين سويت التروما اللي هي involving a surgical part patient care، وفي طبيب الطوارئ اللي بيشوف المريض في الطوارئ أيضا ك ER physician. فكل هالاثنين can lead you into trauma subspecialty. في سؤال ثاني ولا؟
لا دكتور خلاص.
أوكي. And you guys are always welcome to call me and communicate معايا لو احتجتوا أي حاجة، سواء أنت في جدة أو خارج جدة أو في مكة. طيب now we'll start with talking about the actual trauma. This was a bit of introduction. Now it's about how you evaluate a trauma. Always, and I'm pretty sure you go guys by ABCD. So what's ABCD mean? Now when patient comes, always go by the principles of ABCD. A stands for airway. Always start by evaluating the airway, evaluating patient airway patency, and it goes always with C-spine protection. So these letters stand for comprising two things: airway and C-spine protection. B, breathing, which is the word of breathing. You are actually moving your muscles. You are exchanging the air with outside, and it goes with ventilation or oxygenation. This means you're actually using the air going into your lung with exchanging O2 versus CO2. So airway and C-spine, B, breathing and ventilation, C, circulation, which is the vital signs, you evaluating the blood pressure and oxygen, and stop the bleeding if there is a bleeding. D stands for disability, which is the neuro evaluation, and the exposure and environmental control. You don't want to you don't want to expose your patient and causing him hypothermia, and definitely you don't want to deal with a patient who actually in danger. For example, somebody who had chemicals on his body and you are evaluating his airway, his breathing and circulation, and you control all of them. And you miss his the chemical on his clothes and the unsafe and causing him harm. Okay. Fine. Again, so in trauma, we start by rapid primary survey. And then which is the ABCDE, and then adjunct, and we'll talk about it. And then we go to detailed secondary survey with reevaluation, head to toe examination, and then adjunct. And then you transfer your patient to their next stop with an OR, ICU, CT scan, another hospital. So you want to transfer your patient, and then you provide the definitive care to this patient in this place. And this shouldn't, all the studies says it should not take more than 1 hour. So the decision has to be within or the all the trip or the management shouldn't take more than 60 minutes of patient arrival. Okay. So the primary survey is like this, as you can see, guys, in the picture. The trauma team leader stand at the footstep, like the foot side, and he oversees everything. Two people evaluating the airway and trying to intubate, a nurse or two taking care of measuring the vital signs and drawing blood and evaluating the C, another person who is evaluating the B. So everything goes simultaneously. and together. So the ABCDE shouldn't take more than 2 to 3 minutes. So it's always about teamwork, as I mentioned earlier. It's not a single man show. It's always about teamwork. So trauma, in order for trauma to be successful, you have to have a good team, each one dealing with something. Okay, things are clearer now. طيب كنت بقول انه الدراما evaluation and resuscitation goes simultaneously. Everything goes together. Within 2 to 3 minutes, you should be able to get the airway, the C-spine, the breathing, the ventilation, the circulation assessment, and stopping the bleeding, all controlled and looked after. Right. You can see where usually the team distribution, except like the team leader should be at the foot pedal, and the leader always should not be involved, should not be taking care of specific things. He should oversee everything and pointing or assigning people to a specific task. Okay. Pre-hospital preparation. So assume we get a call and we got, let's say somebody, the AMS called us and says, I have a 25 years old patient uh, coming with RTA. Usually there's protocols in each city where the patient get transferred. Usually it's not the nearest facility, it is the appropriate facility. So if somebody with head trauma got hit in a hospital where there is a non-neurosurgeon, they shouldn't be transferred to that hospital. They should be transferred to a hospital where they have the capability of dealing with head trauma, even if it's farther, even if it's not the next hospital, the patient should be transferred where he got the maximum care available. Usually, the pre-hospital personnel is very well trained on taking care of the patient during transfer and in the scene. A safe transfer from the scene to the ambulance, a safe transfer inside the ambulance, and safe transfer to the hospital where they are able to intubate, to use basic medication, to start IV line, to maintain airway. If you have the privilege of knowing trauma patient that he or she coming to you, always is vital to be prepared. And as I said before, time is essence. So if you know that there's a trauma patient coming, always to get your team ready. You call your anesthesia colleagues, you call your surgery colleagues, orthopedic colleagues. Everybody should be in the trauma bay, ready and waiting. It's always good to check your equipment that it's working. The last thing you want is trying to intubate the patient, and all of a sudden you find that the laryngoscope is not working. And the last thing you want is trying to put a chest tube on a patient with a tension pneumo or a hemothorax and trying to find the needle, and nobody knows where the needle is. So always you need to check your equipment. You want to make sure that you have the proper equipment and the proper sizes of the things you might need. The other thing, apart from preparing yourself, preparing your team, preparing your equipment, you want to prepare the hospital itself. X-ray, laboratory personnel. You want to make sure that you have enough blood in the blood bank if just in cases it's needed. You want to make sure that ICU is aware. You want to make sure that the OR is aware that there is trauma patient might need to go to them. You don't want them, especially in hospitals where there is at night one or two people operating in one room or two. You don't want this room to be occupied, and this will delay managing your patient, right? So preparation is vital. And definitely, you want to get yourself protected with started precaution, gown, gloves, face mask. And sometimes we just forget, right? We forget about ourselves. So it's very important. You make sure that yourself is protected from patient blood, vomitus, dirt, chemical, whatever the accident or the trauma caused to the patient. You don't want to get affected. There's transfer agreement between hospitals and each city or if each governors, they decide where the trauma goes with the suspected injuries. And always the quality improvement programs are there. And we are approaching Hajj now. And if you are working in Mecca or Jeddah, you will get every day a drill and simulation scenario just to get people trained, people aware, testing the system in case we had a major trauma or major disaster, la samahullah, we can deal with it. So I'm sure all of you guys know the standard precaution for all of you: cap, gown, gloves, mask, shoe cover, goggles, and face shield. You don't want to waste a very precious minute during intubation to put a face shield on your face to prevent contamination, right? So always be prepared before patient comes if you have the privilege of knowing that patient is coming. Any questions so
Yes, Doctor, there are two questions. Hello,
Go
Doctor.
ahead, please. تفضل.
Does the approach for trauma differ from patient to patient? For example, does the approach for pain in patients like the RTA? This is the first one.
Is there a difference in approach? No,
Mhm.
usually trauma is a trauma, whether it's an RTA or it's a penetrating injury or it's a fall, or if it's a bear, always it's the same approach. ABCD or now XABCD. So stopping extenuating blood, bleeding, and then start ABCD. So this is always will be your approach. So regardless the mechanism of injury, your approach is the same.
The second one, when applying the ABCD approach in trauma cases, what are the most common mistakes you usually see from medical students or junior doctors?
chaos. يمكن هذا أكثر شيء. لما يجينا تروما الستودنتس، اذا كانوا معنا ستودنت ونحن في مكان وي هاف كانت اوف ميديسن، فكثير يجونا ستودنت في مستشفيات مختلفه. بس definitely الكيوز الواحد get stressed out and they get confused. even R1 الزمن R1 وال R2 اول ما يجي تروما يبدا يرتبش، يبدا كده get stressed out. فالاشياء البسيطه اللي بنتكلم عنها طوال السنه ولا بنتكلم عنها دائما اللي هي من جد بيسكلي او بيسكس واشياء بسيطه انتبه فيها، لانه خلاص he's dealing with trauma so he always get consent.
يعطيك العافية دكتور.
Okay, any other questions?
لا ما في خلاص.
Okay. طيب always we do triage. عارفين كلمة triage اللي هي أولويات. You sort out your patients and in life we always do triage. يعني كلكم اليوم قررت انكم انتم تيجوا وتحضروا المحاضره هذه. So this is you triaged ان المحاضره اهم من ان اخرج ولا اروح اتمشى ولا انام ولا اي شيء اسويه. So you are triaging. نحن كاطباء we always do triage in our life. Triaging patient is not different. So always you want to get, especially if you are facing multi-causality or multiple trauma patient, you want to triage them, sort them out based on their ABCD, availability of resources, and other factors like salvageability. أنا متأكد كلكم رحتوا الطوارئ مثلا وكان في واحد فنتلاتور ماشين، يعني جاء حادث وعندنا واحد فنتلاتور ماشين. So you have to pick the most critical patient who really need this ventilator machine. You have to أحيانا تقرر مين حيروح العمليات أول، هذا المريض ولا هذا المريض، لأن نحن الساعة 3 في الليل وما في إلا طبيب واحد تخدير، ما نقدر نشتغل إلا غرفة واحدة على بال ما يجوا الناس الآخرين. So you have to triage. So triage is always vital. Triaging patients on ABCD, it's always important and vital things to you. So in trauma, we triage based on ABCD, we just mentioned. We triage about available resources, and always it's good if you are the trauma team leader, you know what capabilities you have in any given time. And you triage patient based on their severity of injuries. So you don't want to, for example, you have 5 units of blood. You don't want to apply it all for one patient who is extensively bleeding, and these 5 minutes might help, 5 units of blood might help or might not help him. You want to use these 5 units of blood to 5 people, other people, for example, with a minor bleeding, but it will be better outcome. Sometimes it sounds harsh. Sometimes it sounds evil to say, okay, we'll not transfuse this patient, let him die. But in order to save 5 people, maybe you have to sacrifice with one person based on your resources. Again, if you have a lot of resources, yes, it's good to save everyone. But if you have limited resources in any given time, I think you need to triage who you will give the resources you have. Okay, so we'll start by primer survey, and always it's all the same, whether you are dealing with adult, you are dealing with pediatric, you are dealing with elderly, always the same priorities or primer survey. It's the same in all age group or both gender, and regardless of their comorbidity. So ABCD it's the same in everything. Different age group has different characters, but still for ABCD evaluation, it is the same. Primer survey, as I said before, airway with a C-spine protection, B, breathing and ventilation, and you are taking care of life-threatening conditions in the chest, i.e. tension pneumothorax, massive hemothorax, cardiac tamponade. This is taken care during B evaluation. C, circulation, where you stop bleeding, you obtain a proper IV line and start filling the tanks to replace what has been lost in trauma in terms of blood and blood products. D, disability and neurological assessment. E is exposure, environment, and body temperature, as I mentioned before. In children, any questions, Saud, came up?
Yes, doctor. How can a person
أي
maintain
أسئلة
his
جاتك
calmness
سوفا؟
and composure during high stress situations, or does it come
إيش هو؟
with time?
معلش عيد السؤال.
How can a person maintain his calmness and composure during high stress situations? Or does it
ممتاز.
come with time?
Very important question. هل تعتقد انه الكونسلتنت صار كونسلتنت كده؟ يعني ما صار كونسلتنت الا بعد ما يعني تعب، واكيد he did a lot of mistakes during his residency and before becoming a consultant. He was stressed مليون مرة. بس always you gain your calmness by experience, by seeing more patients, by developing clinical sense. So you keep your calmness, you make the right decision. إذا أبغى ألخصها في كلمة واحدة: experience. صح؟ وهذه الاكسبيرينس ما حتيجي من فراغ. الاكسبيرينس هذه حتيجي من seeing more patients, being around more frequently, being awake, aware, cognitive, sharp, more and more. Then you will gain your calmness. Definitely, we all will make mistakes. Definitely, we all maybe will triage in a wrong way, but people learn from their mistake. This is my advice to you if you want to be really calm and making the right decision. Okay? في أسئلة ثانية؟
لا ما في دكتور.
Okay, so children, as you know, the leading cause of death is trauma, whether blunt trauma, drowning, fall. يعني هذه للأسف في الأطفال it's a leading cause of death. Advantage or in children, they have very good response in absorbing trauma. يعني الطيحة اللي ممكن تكسر رجل المريض adult in pediatric, because they can absorb the trauma well, it might not affect them very vigorously. But unfortunately, if they lost it or they lose a compensatory mechanism, it's very difficult to go back to their normal status. And in adult, they have more physiological reserve, but في الأطفال, they have a limited physiological reserve. So if you want to save for kids, always early aggressive care. يعني الادلت بيشنت ممكن يتحمل انه يخسر 2 units of blood or say 500 ml of blood. بس الاطفال لا، لانه their physiological reserve is limited. So if they lost little bit of blood, يمكن الافكت او الريسبونس حقهم ما حيكون سيء او اسوأ من الكبار لو خسروا نفس percentage of blood in their body. So when we deal with pediatric age group, always try to be aggressive in resuscitation. And unfortunately, in pediatric age group, always trauma associated with emotion, صح؟ الطفل بيبكي, you are dealing with the parents. أحيانا الناس يخافوا كده بمجرد ما يجيهم طفل حادث, يخاف يتعامل معاه, يخاف لا يسبب له مشكلة, ما هو متأكد من الدوزز حقت الميديكيشن, ما هو متأكد من السايز حق التيوب ولا حق كانيولا ولا whatever. This is increases physician stress and this makes things أحيانا أصعب. Okay, so as I said, أحيانا a size of tubes with a nasogastric, ATT, cannula, whatever, make it difficult to judge. الدوزج recommend أحيانا anatomical, you know, الاناتومي في الأطفال غير anatomy in adults. So larynx usually it's anterior and more cephalic, and they have a shorter trachea, so you cannot pass the tube long. In infant, we use totally different types of tube, and you have to be familiar with it. in terms of in breathing for pediatric it's different صح الشيست wall more pliable, so it's more safe. They cannot take a lot of trauma compared to pediatric, compared to adult age group. So these all consideration even in circulation and in terms of their neurological status, الانجري في الأطفال it can be worse and it cannot show sometimes في images like adult. Usually in musculoskeletal, they have the green stick fracture. So sometimes patient will sustain fracture in their humerus or their extremities. بس تسوي اكس راي ما تبان لانه عندهم الجرين ستيك باترن. I hope everybody knows. الجرين ستيك يعني زي العود الاخضر انتني، بس احيانا ما يبان لو رجع مره ثانيه ما يبان انه actually it is fracture. So this is all different categories, sorry, differences between adult and pediatric, and you always should keep it in consideration. يمكن كلكم سمعتوا أو شفتوا البيرسلو تيب. بيرسلو تيب شريط يكون عادة في المستشفيات اللي فيها تروما بيدياتريك أو حتى البيدياتريك اي ار، بتحطه عند راس المريض وتمده علين رجوله. And it gives you an estimate of the common medication, of the common sizes of these different tubes, IV access cannulas. هذه الأشياء كلها بتكون مكتوبة في البريسلوتيب. So people who are interested in pediatric and dealing with pediatric trauma, I highly recommend إنكم أنتم تكونوا هذا الشيء معاكم. It really can make difference in managing trauma and it makes you faster. أي سؤال يا شباب؟
لا ما في
pediatric.
دكتور.
طيب pregnancy. So I'll just go quickly about different categories of people and وبعدين we'll move to primary or secondary. Again, dealing with pregnant women has a lot زي ما قلت في الأطفال يمكن في البريجنسي even more a lot of emotional stress لأنك أنت الآن بتتعامل مع امرأة وواحد تاني في بطنها طفل تاني، فبدل ما تتعامل مع شخص واحد تتعامل مع اثنين. ف always it comes with stresses. خايف لا تسوي حاجة غلط، تديها ميديكيشن غلط تأثر على البرجنسي، تديها دواء تسوي iatrogenic injury ولا effect على البيبي. ف always it has يعني different type of stress. بس always stick to the principles ABCD. stick priorities انك انت you save the mother first. If you save the mom spontaneously or consequently you will save the baby. And again زي ما قلنا في البيدياتريك age group and if you took care and you aggressively resuscitate the patient, the outcome will be better. I mean aggressively, we start recognizing the injuries early on, we start transfusing blood early on, we start making sure the airway and breathing are patent, are competent, are sufficient to the patient early on. As you know, guys, the gravid uterus usually in compressing the IVC and inferior vena cava, and it decreases the venous return. So يعني الvenous return للpatient بيكون low already by gravid uterus, and if the patient bled, this causes it even worse. So always when we have a trauma patient, we put them right side up لأنه هذا بيخفف الكمبريشن على الاي بي سي. يعني نحط المريض على الهارد بورد ونرفع الهارد بورد little bit 45 degrees right side up. So this will decrease the physiological hypotension of the patient. They have physiological anemia, as you know, during pregnancy. الامرأة نفسها بتكون عندها anemia. With bleeding, the effect will be profound, will be more on end organs, whether brain, kidneys, or heart. They have less gastric emptying. They have less PCO2 because of physiological tachypnea. And with injuries, لو صار detachment للuterus, this will be a major missed injury in a woman and can cause death. أحيانا مع التروما بيصير isoimmunization, the blood of the baby, if it was different groups, get leaked into the mother and cause isoimmunization. So be aware always of such complication from the trauma. Okay, this is for pregnancy. Any questions, Saud, came up?
No, doctor, there's no questions.
طيب كويس. So for elderly, as you know, يعني الالderly يمكن ما بيتعرضوا لتروما او ار تي اس، يعني واحد جالس في بيته ما بيسوي حاجه. بس unfortunately they always type of trauma is a fall. هدول المرضى بيتعرضوا للفول and complications of the fall, whether fracture, head injury, chest injury. And unfortunately, when we deal with elderly, they are fragile, they are friable, and they have a less physiological reserve زي الأطفال. يعني سبحان الله الكبار بيرجع الفسيولوجي تبعهم الفسيولوجيكال status of their body goes back like pediatric age group. So always be aware, be cognitive في هذا الشيء when you are dealing with trauma. Most of the time comorbidities in elderly and it comes with polypharmacy صح؟ الelderly لو أنا ولا أي أحد adult patient who are not on any medication sustained trauma الجسم can absorb it, but unfortunately in elderly maybe they are on anticoagulant, maybe they are on medication causing coagulopathy, so minor trauma will have a major effect عليهم لأنه المedication might affect especially anticoagulants. Other things, some medications might mask their physiological response. For example, if somebody on beta blocker, and they sustained major bleeding, they will not show the physiological tachycardia other people show, right? Because they are on beta blocker. So be aware of when you are dealing with elderly that not that it's not clear. You need to be more deep. You need to recognize their medication. You need to take a proper history, whether from the patient or the relative, of the medications and the comorbidities they have. Also, the trauma can be secondary to a disease they sustained. For example, in elderly, maybe we receive a patient as RTA or as a fall, but you found out that patient, he just had MI and he had trauma and he fell, right? But nobody picked the MI and everybody thought it's a trauma or it's a fall. Sometimes patient comes with a stroke presenting as trauma, but actually they have a stroke, they have ischemia or hemorrhage in their brain. So always think of secondary trauma due to a medical disease, hypoglycemia, and so on, so on, and so on. So always think of this when you are dealing with elderly people. And as I mentioned before, aggressive early recognition of the problems is guarantee you better outcome. طيب كده اتكلمت شوية على special consideration in different categories of people. Any questions so far?
أيوة دكتور، في طالب هنا يسأل بعض
مم.
المواقف اللي بتكون الموارد قليلة وممكن ما يكون في شخص صاحب خبرة في التيم، مثل أوقات الحج أو العمرة، تمر حالات صعب التعامل معها إما لعدم توفر الموارد أو لقلة الخبرة. إيش التصرف الصحيح وما هي الأولويات؟
طيب أول شيء يعني الحمد لله الدولة الله يحفظها بتسخر موارد عظيمة جدا. يعني أنا من مكة والناس كلهم يعرفوا قديش الريسورسز بتتوجه لمكة خلال الحج، ولكن ستيل يعني أحيانا صعب إنك أنت تغطي كل شيء في كل وقت في كل حين. ف if you are faced with less expert people, I think the most expert in that institution or in that incident should be in charge. ولا يكلف الله نفسا إلا وسعها. We do our best. We do our triage based on the ABCD. وعشان كده بنعلم الناس، وعشان كده الناس بيحاولوا يتعلموا ويطوروا نفسهم، لأنه you never know متى أنت هتواجه such a problem، صح؟ ف الموست اكسبرت try to communicate مع بالهاير authorities، ويستخدم الموارد عنده based on on his or her experience and make a decision. واجين يعني كلنا بنغلط، كلنا we might triage in a wrong way، بس طالما انت you followed the principles. We are always teaching, we are always learning اللي هي ال ABCD الأكشوال الأكشوال triage based on their medical and presentation and their trauma assessment. You will be fine. يعني ما حتخلق حاجة من اللا وجود. ف did I answer this question؟ سعود هذه
هلا
أحسن
هلا
ولا في
دكتور.
شيء ما أدري
لا لا
أخي؟
لا، ما في سؤال
أوكي
خلاص.
طيب كويس. طيب primary survey as I said primary survey always ABCD صح؟ So assessing airway goes with the C-spine precaution. You will assess airway and just talking to the patient and patient replying back to you، هذا معناه إنه المريض his airway is okay, his breathing is okay and his circulation is okay. كيف كده؟ لو المريض اتكلم معاه واتكلم معاك معناته انه his airway is patent, so he's able to move air back and forth inside his chest and outside his chest. فهم سؤالك ايش اسمك ابوي ولا ايش اسمك؟ يقول لك والله اسمي خالد، معناته انه في enough oxygen في جسمه في الدماغ، وهي is able to carry on a conversation. He is awake, he is calm، معناته انه enough blood، ما هو agitated، معناته انه في enough circulation into his body. So just talking to the patient and answering to you back ensure that your three things are okay. Okay, so assessing airway is by talking to patient first of all. If patient is not able to talk, start assessing the patency. If patient is snoring, gurgling, there is stridor, and these are three signs. This means patient need an airway intervention. Let's put it this way: either you put a temporary airway or a definitive airway, which I'll talk about it in a second. Always, when you assess the airway, always think of C-spine precaution, right? If patient is not protecting his airway, this means you need to get the definitive airway. ايش تعريف definitive airway? Definitive airway is a passing breathing tube through a vocal cord or through the vocal cord. كلنا عارفين في vocal cord هنا إذا أنتم شايفين الكاميرا في vocal cord في الحق inside. Once you passed it, this means you got a definitive airway. Either through the nose, through the mouth, or even through opening. أحيانا مرضى يجونا penetrating injury أو الواحد حاول يذبح واحد والairway open. So if you just put a tube through that airway, this means you got a definitive airway. Temporary airway is either ambu-bagging, nasal cannula, oxygen mask, supplying oxygen. This is all good, but if the patient is comatose and they cannot protect their airway, you need to get airway, definitive airway in this patient. Always, when it's associated with facial trauma, it is more difficult. So this means you need more expert. And we all know the most expert person in dealing with airway is anesthesia colleague. So always, if you are in the hospital, and very rarely there's a hospital without operating room, and there is no operating room without anesthetist. So always get the anesthesia colleague to come and evaluate the airway. And sometimes, if you need to bring the difficult airway kit, glidoscope, bougie, a lot of things. Our colleagues in anesthesia, they can have to get an airway protection of patient. Okay, so if say the anesthesia will take some time, so you need to open the airway. There's two ways of opening airway: head tilt or chin lift, and jaw thrust. Head tilt to chin lift is contraindicated in trauma because if you tilt the head, this means you're causing a C-spine injury, right? So you don't want to do that. So always what we do in opening airway is the jaw thrust. You put your finger on the cheek and push the two jaws forward, and this ensure that the tongue come forward and the airway is open. And this is like a temporary way in opening airway till you get definitive airway or doing something to secure the airway. Always look, listen, and feel in the chest. Open the airway and make sure that there is no debris, there is no dust, there is no soiling في الايروي. احيانا المريض خصوصا لو كان حادث احيانا يكون تراب قزاز اشياء كثير يفهموا و unfortunately wasn't picked earlier. So always try to remove any particular matters and try to get frequent assessment. So you will get an airway زي ما قلت يمكن في البداية. You obtain an airway, you go to B and then C, and then you re-evaluate. Always re-evaluate your situation. Okay? Any questions on the airway section?
No, there is no questions, Doctor.
We have patient with a definitive airway. We move to the B. E, where you listen, you look at the chest movement, and you evaluate if there is an enough breathing and enough ventilation. زي ما قلنا البريثنج الافورت حق المريض انه هو بياخد نفس. الفنتيليشن is actually the CO2 and oxygen exchange. الهواء بيروح اللنج, الاكسجين get absorbed and the CO2 get released. So we evaluate locally by chest rise, by symmetry, by looking at the wounds. We listen to the chest entry. Definitely the rate of ventilation is very important if the patient is not intubated, and this will subsequently obtained by proper care of the patient. Patient is not cyanosed or anything. Always think of the life-threatening conditions, whether tension pneumothorax, massive hemothorax, cardiac tamponade, open pneumothorax. So always this is maybe the 3 or 4 things we think about during initial B assessment or breathing assessment. Rib fractures, contusion, other things. Yes, it is important, but it's not that priority at this stage of evaluation. Okay. Always when patient comes, it's good to apply oxygen, even if the patient is awake, even if the patient is breathing. Always when you apply oxygen, if the patient is not stressed, apply through a nasal face mask. If patient is stressed or they're afraid or they're confused, you can start applying it through the nasal cannula, and be aware that nasal cannula will not provide enough oxygen like face mask. And if the patient is not awake and they cannot take a breath, start by ventilating the patient till you get a definitive airway later on. If you think of a tension pneumothorax or massive hemothorax, tension pneumothorax, you need to do a needle decompression. And you all know, guys, it's in the fifth intercostal space in the anterior axillary line where we apply a needle. هذه نفس الكانيولا اللي بنستخدمها للاي line, but a big needle. You don't get a 20 gauge or 24 gauge. You need 16 gauge. You put it and you decompress the tension while you are inserting a chest tube. And then you go for chest tube later on. If you think there's an open pneumothorax, you don't want to air to entrap, you do occlusive dressing where you allow air to go out, but you are not allowing air to go inside. And always reassess. You saw that in the airway slide, and this again, you reassess. Whenever we deal with trauma, we do intervention and reassess the whole cycle. So we put a tube, for example, in the B, and then reassess the airway, reassess the ventilatory machine if patient is intubated. You reassess the air, the ETT, and then you go back into the breathing and reassess that patient benefited actually from inserting chest tube. Okay, circulation. Always resuscitate with blood and blood products. And be aware of different categories. Children, they're normally tachycardic. So if my blood pressure was 120, I'll be considered as tachycardic. This means I'm bleeding. But if you have a kid who's 2 years or 3 years and their heart rate is 120, this is completely normal for them. Elderly, usually if they are on beta blocker or they are on a medication controlling their heart rate, or they have a pacemaker, be aware that this might affect the heart rate response. Athletic, and we all know athletic people might have less heart rate in order because they have a good stroke volume. Pregnancy, and we just talked about this, and medication, we talked about it. Be aware of non-hemorrhagic shock. So in trauma, the most common cause of shock, the most common cause of being hypotensive and tachycardic is bleeding. So bleeding till proven otherwise. But be aware of non-hemorrhagic shock, i.e. cardiac tamponade, tension pneumothorax, neurogenic shock, or septic shock due to, for example, bowel injury, missed bowel injury, contaminated wound, and this is usually late after 48 hours and more. But if you have a fresh patient came to you who is in shock, always think of bleeding. If you excluded bleeding, start thinking of other causes of shock. Okay. Right. So how we assess if the patient is in shock or no, part of your circulation assessment, we assess by definitely vital signs, heart rate, and blood pressure. And if we have enough blood in the circulation, if we have enough blood in our body, it will be delivered to different organs. If we have less blood, it will be directed to the 3 main organs in our body: heart, brain, and kidneys. So if a patient presented with altered level of consciousness, apart from causing his direct head injury or other causes causing him to be altered mental status, you have to think of patient is lacking a lot of blood. Because as I said, if you have less blood in the body, it will be directed into the brain. So if the patient mental status changed, this means there is no blood going into his brain, and this means he lost a lot of blood. It's not a small amount of blood. So tachycardia, vasoconstriction, because as we said, when we have less blood in our body, it will be direct. So the extremities will have vasoconstriction. there is no blood into upper and lower extremity, no blood into the gut, all the blood going into the kidneys, heart, and brain. If less blood, patient will have more hypertension, less cardiac output, narrow pulse pressure, and decrease in their blood flow. Okay. Again, you have to be careful with these types of people and these categories of patients. Okay, so part of the C assessment, we assess the status of the body, and then you have to stop the bleeding. In trauma patients, usually there is not much places to bleed from, either your chest, your abdomen, your pelvis, the extremities, or external bleeding. For example, somebody with a major scalp bleeding, they bled into the field and they came in no active bleeding, but it was external bleeding and it went. Now there's no bleeding, but it's already stopped because there's no more blood in the body to bleed from. So always try to find the source of bleeding. If the chest, I think physical examination and a quick chest X-ray will indicate there is bleeding in the chest abdomen, and usually we do fast. Pelvis by clinical examination and fast, and extremities, whether femur, tibia, or humerus, by physical examination will indicate if there is a fracture and associated bleeding. We stop the bleeding by direct pressure, by surgery sometimes, and never just apply blind clamps whether in the ER or in the OR. So always try to find the bleeder and stop it. Nowadays, there is a lot of hemostatic agents applied, whether in the field, in the ER, or in the OR. So try to be familiar with such things, and you can apply it directly on bleeding. So assist circulation and then stop bleeding. Okay, and in order to replace, you need a proper IV access and start restoring the volume in the body. Before, we used to give crystalloid followed by colloid, or I mean blood. Now they have a lower threshold to start transfusing blood earlier because it's more physiological acceptable than crystalloid. So always, if patients came in hypotensive, this means they are in stage 3 shock, and you need to start blood early on. So this is the stages or classes of shock, and we usually assess it by physiological response, heart rate, blood pressure, pulse pressure, respiratory rate, and urine output. As I said, usually if we have less volume, the blood will be directed to the vital organs, and one of the vital organs is the urine. So if you have a low urine output, this means there is no enough blood going into the kidneys. This means patient lost a lot of blood. And CNS, it's got applied the same for brain, and you have to rule to replace them by crystalloid and colloid. And as I said a minute ago, now we tend to give more liberal blood rather than giving them crystalloid. Okay. Again, be cognitive of non-hemorrhagic shock causes of patient being in shock. Tension pneumo, massive hemo, and cardiac tamponade. Okay. Any questions so far, guys, on the airway? Please. So, في أسئلة?
No, doctor, there is no questions.
Okay, good. So you move on to the D, disability. This means you will obtain a neurological baseline neurological evaluation and Glasgow Coma Scale. And it's very, very, very important, guys, to document the neurological status of the patient in arrival, i.e., which extremities he or she is moving, what is their GCS Glasgow Coma Scale. Because most of the time, if patient was on a certain level of Glasgow Coma Scale and deteriorate, this is completely different from a patient who already came with the low GCS. So, and nowadays we endorse. For example, patient came at 7 a.m., you resuscitated, patient was having GCS of 12 or 13, and then you endorse him to the next shift and you left. You did not recommend that patient Glasgow Coma Scale was 13, and they all of a sudden in a busy ER where everybody was not around, they found out the patient GCS is 8. So this is a huge difference, huge drop in their Glasgow Coma Scale, and this is per se is an indication for surgical intervention in terms of craniotomy and evacuating their intracranial hemorrhage if they have. So documentation is very important. Reassessment is very important, and writing down every single details of their neurological status. It goes the same for spinal cord injury. If somebody came in who's completely paraplegic, it's totally different from somebody who came in with and be able to move his upper limb and lower limb, and all of a sudden while we are moving him, we did something wrong, or while we are intubating him, we didn't pay attention to the neck and cause him to be paraplegic, right? So this is very important for you to document their neurological status. Okay? And always, as it's written here, observe for neurological deterioration. This is the Glasgow Coma Scale, which is the most important, accurate method of evaluating patient with suspected head injury. So best score is 15. Worst score for somebody who's dead is 3. Okay, so in head injury, as you can see, patient has compensation, and then all of a sudden, as you can see here, they deteriorate and they go into the irreversible status. So our rule is to pick them before they go into, and this only happens if you have a good physician who is following up, who is reevaluating of their neurological status. Okay. Right. Exposure, as you know, guys, you have to completely undress the patient, because if they are in RTA, if they have came in a pair, came fall, so you need to make sure that we are not missing injuries. So completely undress the patient. Definitely, you want to keep their dignity, their private part are covered, but doesn't mean that you don't examine them. You have to examine the patient properly, because you never know what the injury caused to the patient, right? And then you need to uncover them, because definitely we want to keep privacy of our patient, as well as you don't want to cause hypothermia to the patient, because you know the lethal triad: hypothermia, coagulopathy, and acidosis. You don't want to get patient hypothermic, because it's totally preventable thing by just simply warming the patient and cover them up. Look for visible or palpable injuries, and always don't forget the back. Look roll the patient and examine their back. Make sure that there is no cut wound, there is no debris, there is no injuries in the back, whether penetrating or blunt injury. Okay. So, overview, if you are in doubt, if the patient is not acting well in terms of airway, you are not sure if they can protect their airway or they cannot protect their airway, establish a definitive airway. Always it is safe, it is better to intubate the patient before leaving them unintubated, and then all of a sudden patient develop edema or they lose their airway, and we convert a semi-urgent intubation into a top early into intubation, and you might fail, right? So if you are in doubt, just establish a definitive airway, oxygen for all trauma patients, oxygen never harmful, chest tube. Yeah, if you are in doubt, go and insert a chest tube. I always tell my students, putting unnecessarily chest tube is way better than missing somebody who really needed a chest tube and we missed it, right? Stop the bleeding, two large bore IV, and prevent hypothermia during exposure. Okay? Any question, guys, so far?
There is no questions, Doctor.
Good. So adjunct to the primary survey. After we do primary survey, decompress the bladder. You want to put a nasogastric tube. You want to put a Foley catheter. You want to make sure, especially in elderly, there is no secondary. This trauma wasn't secondary to MI, so you want to make sure that ECG, cardiac enzymes, blood work, all of these things you want to get it done, and this is the adjunct for primary survey. Okay, so monitoring and tube again. Then we do chest X-ray and pelvic X-ray. No more X-ray of the neck. Always do X-rays, and then fast, which is focus assessment sonography trauma, which is the ultrasound basically for trauma. And you need to get patient into their definitive care or transferring the patient if you think this patient is needing a transfer. Okay. Secondary survey, it's always start after finishing your primary survey and adjunct to the primary survey. It goes by ABCDE assessment, and then you do detailed secondary survey, means detailed head to toe examination, and you get you do secondary survey while resuscitation is ongoing. You don't stop the bleeding, you don't stop the blood transfusion, because you want to do secondary survey and you want to examine the patient, right? So as I said earlier, it goes always simultaneously. Okay. Part of your secondary survey is the amble history, and all of you guys know the amble. Now I forget amble. Medical, past medical history, last meal, event, allergy, medication, past medical history, last meal, and event. So this is the amble history. And then you go by head to toe exam, as I said, full neurological examination, and then you do CT scan. Sometimes people say, okay, when do I do CT scan? Do I do it after the primary survey or after the secondary survey? If the patient is stable and time permit, finish up your secondary survey and send your patient to CT scan. If you think there is a huge need for CT scan of the head, or there is a bleeding in the abdomen and you want to reassess, you don't do secondary survey now. You delay it after you get CT scan and get a plan for your patient. And always re-evaluate, and re-evaluate. And this is what I just was mentioning in history. Okay, so mechanism of injury, usually with looking at the anatomy, physiology, and pattern of your injury will tell you a little bit of the mechanism of injury. Okay, so this is where I think I'll stop. We talked about primary survey, teamwork. We started by teamwork, and then primary survey, adjunct, and assessment, and then secondary survey, and when do you transfer your patient to your definitive care. Any question, guys? It's a long talk, but I thought we'll just touch base on these initial things or essential things. Any questions? أي سؤال عندك سعود؟
Yes, doctor, there are two questions. Uh, Someone asked, Doctor, if I encountered a patient with neck trauma with active bleeding, oozing, and the patient had his C-spine from EMS, at what point I can temporarily remove the C-spine to examine and assess the wound in the neck?
So definitely it's part of your airway assessment صح لأنه ما تبغى إنك wound يكون penetrating وبعدين you don't know how to deal with it, right? So if you have neck wound I would assess it during my primary survey. لما أجي أسوي airway assessment طبعا ما تشيل الكولر كامل بس أنت هتشيل التشيك هذه تفتح الكولر while we maintain the airway or C-spine alignment, you examine the wound and you reapply and color.
Other question. Can you explain chest tube further? Is it used in all chest trauma or for what exactly? And why it's better to use chest tube when I'm not sure if it's indicated in this chest trauma?
ما فهمت عيد السؤال.
Can you explain chest tube? Is it used in all chest trauma or for what exactly? And why
Okay.
it's better to use chest tube when I'm not sure if it's indicated in this chest trauma?
Okay, fair enough. So ما هو bluntly ولا blindly انت بتستخدم الشيست تيوب لكل التروما. If you have hypoxic patient who you are 100% sure that he is the ETT or the airway is protected or there is a definitive airway وstill المريض hypoxic, you suspect انه المريض هذا يمكن عنده pneumothorax. يمكن you have the suspicion. It's better not to wait for a chest X-ray, not to wait for CT scan, وتحط chest tube. هذه هي أنا what I mean better to use unnecessary chest tube better than missing somebody who need chest tube. فهمتوا يا شباب؟ يعني ما هو blind لأي مريض with a chest trauma تحطوا له chest tube. I'm talking somebody who is hypoxic, who you are 100% إنه ما عنده مشكلة في الأيروي، معناته إنه عنده مشكلة في البريثنج. By your clinical exam المريض عنده bruises، عنده wound مثلا في الرايت سايد، عنده crepitation، عنده evidence of rib fracture by clinical examination، معناته انه البروبابيلتي انه عنده chest pneumothorax او البروبابيلتي انه عنده pneumothorax is high. فما تستنى لين نسوي chest x-ray الا تاخذ وقت ولا تاخذ المريض على السي تي سكان وتقول والله خليني استنى واكون متاكد. لا، you go ahead and put chest tube. اما واحد جاء حطيت له اي تي تي والاكسجين ساتوريشن 100% والشيست ما في ايفيدنس اوف تروما او في له ايفيدنس تروما بس ما في هايبوكسيا، لا ما تحتاج تحط له شيست تيوب. اوكي، واضحه؟
ايه واضحة دكتور.
اوكي
طيب الظاهر كان هذا آخر سؤال.
طيب، الله يديكم الصحه والعافيه.
شكرا
I
لك
was
دكتور.
honored to be with you guys. أتمنى إنه يعني الجميع استفاد أو البعض استفاد. لو واحد خرج من المحاضرة وحس إنه he learned something, I'll be very honored and blessed. You guys are all welcome to join or to communicate معايا إذا عندك أسئلة في التروما. إذا تبغى تسوي الليكتشر معايا تبغى تيجي. I work at University of Al-Qura. I work in Security Forces Hospital in Mecca and I work in Saudi German Hospital in Jeddah فرع الزهرة. ومرحبا بكم كلكم تتواصلوا معايا على تويتر أو ممكن إنكم تاخذوا جوالي من الأستاذ سعود أو الأخوان في الأكاديمية. يعطيكم الصحة والعافية إن شاء الله وشكرا لكم.
شكرا لك دكتور باسم على هذه المحاضرة القيمة. جزاك الله خير. برضو أشكر جميع الحضور من طلاب وطالبات الطب على تفاعلهم. نتمنى أن تكون المحاضرة قد حققت لكم الفائدة إن شاء الله. كما نسعد دائما بمشاركتكم في مثل هذه اللقاءات ضمن مبادرة تجمع طلبة الطب حول المملكة. شكرا لكم جميعا ونلقاكم بإذن الله في لقاءات قادمة.